All right. And so this is a presentation that Ari Mueller and I did at the Mass AFP meeting. And what it consists of is there's a variety of very small blurbs. In a few minutes, you guys will have the opportunity to choose which ones you think are most important to you. And I'm really sorry that Ari isn't here today because she's actually way more qualified to give this talk than I am, being an ex-hospice director. So she might be able to answer some of the questions I can't, but any questions you guys have that I can't answer, I will take down and get back to you with. She's not here, for those of you that don't know, she's busy gestating triplets. So she's having triplets. So for the last several weeks, she has been very busy concentrating on that rather than here at work for understandable reasons. So our goals and objectives for no financial disclosures, that's still in for us. So, and you guys can choose sort of amongst these what will be the priority. But utilizing MOLST forms as a tool appropriately for referring and co-managing with hospice, and palliative care is distinctive from hospice, and expanding the knowledge base and toolkit for end-of-life care and symptom control. So to start with, if you can go in, I'll go into the poll everywhere to text my name 350 to 22333. I'll give everybody a minute to do that. And then once you've done that, you can go ahead and choose which topic you're most interested in, and we'll go through them in the order of interest. So advanced directives and MOLST forms, palliative care and hospice, hospice eligibility criteria, end-of-life discussions, end-of-life symptom management. So those of you that are just coming in, if you want to text my name 350 to 22333.
And we're responding.
No, I don't think it has. I don't think capitalization matters. So, if you're getting in, tell me if that's working. It should be, but if we have issues with that, we'll go to old-fashioned digital technology and have you raise your hands.
We have to pick just one.
For now, we're going to pick just one. I couldn't figure out how to make it let you rank without it being really complex. So. So I'll wait a couple minutes until I don't see people working with their devices, and then.
Okay, what's the question?
Oh, the question is what you're most interested in. So these are little mini blurbs or topics. So we're going to go through in order of you guys' interest. So pick the one that you're most interested in hearing about, and we'll go through in order of people's interest. So we'll give it another 30 seconds or so. All right, so it's looking like, oh, there's still people coming in. But it's looking like definitely end-of-life symptom management and MOLST forms, and then maybe, so end-of-life, palliative care and hospice. Okay. Those are tied, so we'll see. All right, so we'll go to the end-of-life symptom management first. Then, since that's, and I am leaving, for full disclosure, I'm leaving out the complementary medicine piece that Ari would have done because I feel unqualified. So you guys are unfortunately missing out on that today. Okay. As I said, this is just going to be brief blurb on end-of-life symptom management. So starting out, you have an 85-year-old patient with metastatic breast cancer who's receiving palliative care. The goal of families is to stay away from the hospital. She's developed intractable nausea and vomiting, really miserable. You've been giving her Zofran. Initially that helped. Now she's vomiting through the Zofran, really miserable, struggling. And Of course, first, you make sure that there's not a reversible cause of nausea and vomiting. So you go through your differential, try to think about possible medications that could be causing this. Is there anything in her clinical picture that could be causing the nausea and vomiting that you can change? That's number one, of course. You do all that, change what you can, she's still vomiting. So what would be your next choice for trying to help control her nausea and vomiting? I'll give you a minute again to all think about it and vote. Okay. All right. Good. All right, so you guys far and away voted for Reglan. So Reglan's not an unreasonable choice. That probably wouldn't be the top choice in the palliative care literature for a couple reasons. One, Reglan has some pretty significant side effects that it can have, particularly at the end of life. And the other thing is that Reglan, unless you specifically have gastroparesis as the etiology, which you may, in which case this would move further up the list. If gastroparesis is not the etiology, then if you're failing Zofran, then Reglan usually is not going to give you that much of an additional effect or additional bump over the Zofran. So Reglan is not an unreasonable choice, but it might not be the very top one. Some people chose Phenergan. It's an oldie but goodie. Probably the residents are not choosing that so much because we don't use it nearly as much as we did when, well, Stephen's younger than me, so I can't even say when we were in training, way back when I was in training. Phenergan's not a totally unreasonable thing. Again, in general, Zofran is more efficacious than Phenergan is, with somewhat fewer side effects. So you probably won't get additional gain from Phenergan if you're failing Zofran. Marijuana we'll kind of leave to the side since we're not allowed to prescribe that. It may be that will be more of a part of our armamentarium in the future, but we can't do it here. And at least right now, the process for getting someone marijuana is a little bit clunky. So if she's vomiting today and you want to have her something by tomorrow, then that's probably not going to be what's going to happen. So we'll leave that off to the side as something that maybe further discussion in the future in this setting. Haldol is actually a very effective antiemetic in this situation, and that is Haldol is probably your first choice in this situation, and it can work quite well. Some caveats with that, if Jen Sparks is here, she'd speak up and say, in nursing home patients, it's hard to get it because there are all the rules about giving antipsychotics in nursing home patients. So that may be an issue. However, if you have a patient at home in the home setting, in the hospice setting, Haldol can be very effective and often can be a really big blessing for people.
Kara, can you talk about the dose? Oh, sorry.
Yeah, absolutely. So there you go. So you can start at the low end because as Haldol does also have some significant side effects. So you'd start at the 0.5. You can do PO or you can do IV if you have someone that has an IV every 4 to 8 hours, and then you can titrate up as you need to as much as 2 milligrams. So you have a little ways to go. And again, there's nothing that's perfect, but with a lot of people you can get very good control with Haldol used in this way. Okay. So for whatever reason, I'm going to try to go back in my slide because for whatever reason, having a pull everywhere seems to make things go up into the sky. And I couldn't figure out how to fix it. It does that about 25% of the time. I'll reset it. So this is an off-label use. That's not one of the FDA-approved indications. Other options for intractable nausea and vomiting, scopolamine patches actually can be very helpful. You have to be careful, of course, of the anticholinergic side effects, really dry mouth. Sometimes people can have some psychosis with it. But it can be helpful for nausea and vomiting, and it's particularly useful because it is a patch. So if you have someone that's having difficulty tolerating PO, they're at home, they don't have an IV in, this is a good way to get something in to help with their nausea. And you can use a double dose, so you can use 2 patches if you need to, if they're tolerating the side effects. Particularly in someone that has tumor and has obstruction, combination of dexamethasone and octreotide can be really helpful. And that can get people a lot of comfort at the end of life when they have an obstructive process that's causing nausea and vomiting. All right, so nausea and vomiting are better. she's now getting morphine for pain control. So you're writing a morphine prescription for her, and along with the morphine, what do you want to choose? Oh, and it didn't, yeah. And I'll tell you the mistake that I see on here that I made. Okay, great. And actually, my intent had been, to put, had been to put Senna with Delcusate, so Senna, a combination of Senna and Colace in there. And when that's the case, it would be any of the above. Typically, Miralax is one of the top choices that you can use. You can also use Senna alone or Senna with Colace. Lactulose is also a reasonable option. Fleets, you don't usually want to start with Fleets enemas, but that's someplace that you could get to if you needed to. The one thing that is probably, two things that are probably less effective in end-of-life constipation are Colace. So if you're using Colace by itself, so that's essentially a surfactant, and it is a stool softener. If you're using morphine, a stool softener usually just does not have the oomph to get them to poop. So that's usually not going to be enough. So if you're starting someone on a long-term narcotic, you usually want to do something that's a little bit stronger than the Colace. So you can either do straight up Senna, you can do the Miralax, you can do Senna in combination with Colace, and that would work well. The other thing that you want to probably try to avoid in end-of-life care with opioid-induced constipation is you probably want to stay away from bulk agents like Metamucil. So what do you need to do together with the Metamucil to make it work? Drink lots of water. And if you have someone that is at the end of life, suffering, they're probably having issues with how much PO they're taking and how much fluid intake they're able to have. If you just take the Metamucil and you aren't able to take the water along with it, you'll just end up with a big glob of fiber that you can't get out and then actually can cause problems of its own. So essentially the bottom line is you want to make sure you write something. Almost anything is okay. You want to try to stay away from Metamucil and probably stay away from straight up Colace by itself. In combination with other stuff, great, but probably not by itself. All right. Yeah, and get away, obviously, taking away anything else that may be constipating. And the other nice thing about Miralax is that there's no maximum dose, so you can just keep going up until they poop. Because it's not absorbed into the system, there really aren't systemic side effects with that. The other two new medications that you may or may not have heard of, methylnaltrexone, or Relistor, is specifically approved for opioid-induced constipation in people that aren't responding to other stool regimens or continue to have difficulty. It's subcutaneous, so it is a shot. That can be a benefit in someone that's having difficulty taking PO, and you can't really titrate your Miralax up because they just can't take that much in. Even newer than the Relistor is something called Movantik, which is oral formulation, so that's a pill. I don't know if anyone's ever used Movantik. I haven't used it yet. Did it work? It's really expensive, so yeah. So I think that it is, and I think it is, Relistor is also very expensive, but I think it's still easier to get Relistor than it is to get Movantik. Okay. So now, even closer to the end of her life, in probably the last week, or the last few days, and she's no longer able to effectively clear her secretions. You can work on repositioning. Fans are a powerful intervention that is underused, probably. That can really help in people's comfort level. So, any recommendations for her secretions? And this is a little bit of a trick question, as we'll come to another slide. But all right. Yeah. So any of the above are things that can be used. So all of those things are possibilities. I noticed nobody chose the atropine eye drops, and I haven't actually ever used those myself either. But they are out there in the literature as an option. It's also sublingual, so it's relatively easy to use and relatively easy to get in for people. So again, you can use Levsin, which can be PO, sublingual, or you can use, again, scopolamine patches. So scopolamine patches can do double duty for nausea and vomiting and issues with secretions. So any of these things can be used. The caveats on the next slide. So all of those things that are up there, very anticholinergic. Some of them can induce psychosis. There's significant side effects that you can induce with these things. And really important to balance out, because in the hospice literature, there's a lot of suggestion that people who are having excess secretions at the end of life are much less troubled by that symptom than their family is. That it appears to be much more uncomfortable to someone that's watching than it actually is for the patient who is experiencing it. So you can talk to the family about that and balance out how much you're treating the patient versus treating the family. So it is very reasonable, if the family's comfortable, to use other measures, wipe away the secretions, use the fan, cooling devices, repositioning, those kinds of things to make the patient comfortable and not specifically treat for this. However, in instances where it is severe or the family does elect to treat, any of those things in addition to glycopyrrolate are options for excess secretions. All right, so that was our first little blurb, and next we were going back to advanced directives and advanced directives and MOLST forms as the next topic that you guys chose. So your first thing, MOLST forms are the state of Massachusetts approved advanced directive forms designed for use with geriatric patients or patients with severe chronic illness. True or false? Good. Okay, so this is good. This gives us something to talk about. So this is a trick question, right? To trick you guys all into saying true, right? So, and the key word here is advanced directive forms, right? So I have an advanced directive, right, that says, in the event that I am in a situation where it's extremely unlikely that I'm going to recover from it, I don't want aggressive life-sustaining measures in that situation. That's an advanced directive. That doesn't mean that if I get in a car accident tomorrow, they're not going to intubate me, right? And that also doesn't mean that that an advanced directive doesn't take effect today when you sign it. It takes effect in the event that you are in a situation where you are in a position where you're very unlikely to recover from something, right? So an advanced directive is a kind of if-then kind of proposition. What does MOLST stand for? Massachusetts Orders for Life-Sustaining Treatment. So the MOLST form is an order, right? So if you sign an order, that's for right now. That's not for if, then, tomorrow. That's for right now. So when you're signing the MOLST form, that's an order for what you want to happen right now from this instant forward, no matter what. So that's a little bit of a different discussion than an advanced directive, right? So the MOLST forms are designed for people who have illnesses that would make it to where they were towards the end of life, or for people that are very elderly and are making that decision based on their life status at this point. So the MOLST form is not something that you and I are going to go ahead and sign and fill out right now. It's not something that you're going to universally do in all of your patients. It's something that is specifically designed for the end-of-life setting. All right, so not advanced directives. Immediate effect. So you want to think about that when you're signing forms. And there have been issues in Massachusetts where that's kind of come up, where there have been MOLST forms signed as an advanced directive, and someone has a MOLST form with them, and they're going into the emergency room, and the ER is like, but you're a relatively young, healthy person. What is this doing? And that can lead to communication errors and problems. All right. So next, available only in English. Yeah. So you guys are getting wise to my to You're not going to be able to be tracked now. Yeah. So because they are order form, so there are permutations that are in Spanish that or other languages for people to look at, but this is an order. Just like you can't write an order in the hospital in Spanish, you don't complete a MOLST form in Spanish with the family. You can go through and, of course, talk to them and give them reading materials that are appropriate to go along with that, but the MOLST form to be effective is only in English. Okay. And the other piece along this is they are designed to be orders. So they're designed for you as the clinician to have a discussion with the patient about their end-of-life wishes. And then this is a means for you to document them. It's not designed as something to give to a patient and say, oh, this is something for you to talk about with your family. Think about, fill out, and come back to me, and we'll sign it together. It is designed for clinicians to be a tool for documentation of the communication and discussion. So this isn't so much a patient handout. It's meant for communication among clinicians. The language on there is not designed to be patient-friendly. It's designed to be for clinicians. Okay, so this is a form that's designed to document that communication. However, that is the standard form that's used in the... We do have them in the clinic. I think that is variable, like with all the paper stuff that we have in the clinic.
Yeah.
I don't know about it north. I know at Haverhill Street they are around, but can be very difficult to dig up.
We talked about this just last week, and we're putting together a file cabinet concept that's going to get plugged in up in the upper right-hand corner. You can click on forms right now. There's like there's a thing for looking at pap smear protocols, a bunch of others. We're going to try and generalize that into a file cabinet, and one of the file cabinet drawers will be end-of-life forms and allow you to print those. Although generally, as you're about to find out, it's preferred to be printed on different color paper, but at least make the form available for you to sign and worry about the paper later. And we're looking to change, if you've seen in the EMR, there's a section that's called directives. It looks like allergies. Like there's a section for allergies and a section for directives. The directives are very odd. They're like US-wide, so there's no concept of a MOLST file. And we tried to fix that last week, and it turns out there's no place to fix it. So we filed an error report with GE and said, we don't like yours, we want to change them. And they haven't gotten back to us to how you change those. So there's only like a weird set, like I think it says advanced directive was filed. So I would use that for now. Just check that off, and it will show on the chart that was done. And we'll fix it later to say healthcare proxy, MOLST, whatever, once we figure out how to fix it.
Yeah, and so it is also, you can if you just Google MOLST, it immediately comes up and you can print it out. So it's not difficult to access online. The trick is that it is valid on any color paper. But the recommendation, the preferred piece of paper, particularly if they're going to have it in the home, is the bright pink, because EMTs are trained to look for the bright pink piece of paper, and for that to be easily recognizable. That's a little bit of a barrier for us because we struggle to keep paper copies of things. So I think that's going to have to be a work in process that we're working on. The other thing that is really nice about the MOLST forms, if you look at it, there's two sides to it, right? So there's front and back. The front side has the kind of traditional DNR, DNI kinds of things when you want to be transferred to the hospital. The two sides are actually valid independently. So you can use both sides together, or you can use one side or the other if you so choose. On the back, it has, again, intubation and ventilation and CPAP. In addition, it talks about dialysis, artificial nutrition, artificial hydration. In some patients, you might want to just talk about the front part. You're really doing the straight-up traditional DNR, DNI kind of discussion, and you could just use the front part of the page for that. Other patients, you might want to have, in other situations, you might want to have the more extensive discussion. The other thing that's really nice about the MOLST form is if you look at the back part of it on the second page, when you look under intubation, ventilation, non-invasive, dialysis, artificial nutrition, artificial hydration, in all of those, there is a checkbox available for short-term only. And I think that's a really nice thing because that's not necessarily an option in the traditional DNR, DNI forms that are either yes or no. And I find that that's something that is the most comfortable for a lot of patients who will say, I really feel like for me or for my family, my family is going to feel like I'm not trying if I say I don't want these things. I don't want it for a long time. Okay, go ahead and do this for a day or two. If it's not working, that's the end. And that's something that you're able to document on this, that it was more difficult to document in traditional DNR forms. So that's a really nice checkbox to be available, that you can have that for people that want a brief trial. However, if there's no response to the trial, then stop. All right, yeah, so the short term only. All right, so advanced directives as separate from the MOLST. So these are the things that and probably in reality it would be wonderful if we were talking about with all of our patients, time limitations, and it's difficult to do, but we can at least choose the subset of patients in whom it's most beneficial and try to be doing this in our patients that are in the geriatric population. So these, like we talked about, not effective immediately, only if the patient becomes incapacitated, and many of them only if they're in a situation where they have an illness or a situation that they would not recover from. So these are designed for patient and family discussion to think about, to talk about over the Thanksgiving table. There are a variety of them, and I meant to bring the 5 wishes and hand them out, and I didn't. So I'll run and get those. So for anyone, I think most people have seen those. If you haven't, I'll run and get them at the end so that you can look over those. 5 wishes is really nice and lovely. The difficult thing about 5 wishes is that it does have to be in that packet that they send you, and it costs money. So it's difficult for us to have those available easily in clinic because it costs some money. For me, because I see lots of geriatric patients, and I do my own home visit patients, it doesn't cost that much money. I just buy them to have them.
How much money does it cost?
So you can get like a packeted, it's like $1 a piece essentially. So it's not a huge deal to do a small number. For the clinic, it would be a bigger deal to do a huge number when we know how things kind of disappear and walk around. And so the nice thing about healthcare, 5 wishes again, is that it includes the kind of traditional kinds of things that we would talk about, like a healthcare proxy and a more traditional living will, but also includes the opportunities for discussion around what else that person would want. So the kind of their wishes for comfort care, and this is around things like, I really want to be at home if at all possible. I don't want to be in the hospital. Wishes for how to be treated, and this is, I love music. These are the things that I want playing all the time if I am near the end of my life. Either, I want to be prayed for, and I want people around surrounding my bed praying for me, or stay away from me with prayers. That's not my thing. Don't do that. Whatever your wishes are for, the patient's wishes are for how they want to be treated. And then there's a really nice section at the end about what I want my loved ones to know. And for all of these things, there's kind of suggestions for things that a lot of people might want, and you can mark through the ones that don't apply to you, circle what you think does, write in whatever you want. Those can be used really nicely around the Thanksgiving table conversation kind of thing. On the back of the white handout, the front of it has some resources and literature. The back of it has end-of-life resources for families. And there's 3 of them that I highlighted. The Conversation Project is one that you may have heard of, that is the first one. That has a free PDF or starter kit that families can order online. And this is kind of the idea of having the Thanksgiving table conversation. And it gives families tools to to start that conversation and to start that discussion. The hard thing about all of these is that there is some Spanish translation available, but most of these are not straight up easily available in Spanish. So that is a limitation with the resources that I'm showing you. So the Conversation Project is for family discussions, talking about this together as a group. The Stanford Letter Project is designed for either a patient or a family to go through together and design a letter to their doctor about what their wishes are. So this is can be patient initiated, that they can go through and have that discussion and then bring that in to the clinician as a record of what their wishes are, and then you as a clinician can then go through and fill out additional paperwork as appropriate based on their wishes. Vital Talk is a resource that's for clinicians. So this is a website that has actually a wonderful wealth of information and frequently asked questions and how-to guides around discussions around end-of-life care. So this is not a patient resource, not so much as a resource for us when we're in a sticky situation and would like a little bit of guidance. All right. So we have, I guess, I'm not sure if we're supposed to end at 10 till. We have another 15 or 20 minutes. You guys had tied with end-of-life discussions versus distinction between palliative care and hospice. Which, you want to vote real quick. So everybody that wants to do palliative care and hospice, raise your hand. Okay. End-of-life discussions. I think end-of-life discussions, it looks like. That's what we'll go with. All right, I'm going to skip this one because we already did this. So the MOLST is not necessarily designed as a framework for the discussion. And specifically with the MOLST, I know all of you guys have probably either witnessed or heard about, the end-of-life discussion where there's someone sitting here. Well, if your heart stops, do you want us to start it again? Do you want us to put a tube down your throat if you stop breathing? Do you want us to start dialysis? The checkbox kind of approach to this. That probably is not terribly effective. And that's the reason why this is not really designed as a guide for the discussion. Because if you're sitting there with a paper in front of you, it's really easy to just do a checkbox approach, to what you want checked. The other comment about that is that a lot of times the end-of-life discussion I've seen lots of times framed as, if your heart stops, do you want us to shock you and restart it? Or if you stop breathing, do you want us to put a breathing tube down and start you breathing again, essentially? So what's the premise in that question that I just said there? I'm sorry?
Success.
Absolutely. The premise is that we can do it. Do you want us to restart your heart? Well, sure. Why not? You guys are all powerful. Why not? It always works on TV, doesn't it? So when you're framing the questions, it's really important to be cognizant of how it's going to be heard, and that you want to frame this as something that can cause very significant distress, and as something that is successful in a fraction of the times that we attempt it. So just to think about the wording and how that's going to be perceived by patients. The other thing, if you're starting this discussion, harder when you're in the emergency room doing a bunch of admissions, but when you're doing a family meeting, when you're seeing a patient in clinic, when this is someone with cancer, or when you're in the ICU too, if you can start with letting the family or the patient tell their story a little bit, that can really inform the rest of your discussion. And I will give an example of that from back several years ago in the ICU. We had a patient that was from Africa, had come here from Liberia. Sister was here with her, and I don't even remember the medical details, but she was in the ICU in multiple failure. She was dying. This was a young woman who was in her 40s. It was a really tragic and horrible situation. And over the course of a week, there had been bunches of family meetings and discussions about what the goals of care were. And the family, the sister, had been really struggling around the fact that she was dying, what we were doing, why we couldn't do more, and was really kind of pushing for very aggressive interventions that weren't necessarily indicated at that point based on the medical facts. And I was sitting down with her on a Saturday morning with one of the residents, and the resident asked her to tell a little bit more about her sister, what her sister was like. We didn't have the opportunity to know her when she was healthy. What's your sister like? And things just came spilling out about how this woman had never had any children of her own, but was a teacher and had the inspiration that she had been for so many children in Liberia, for children, nieces and nephews, the children in their family, what a giving person she was, and the difficulties that she'd been through in Liberia, some violence really tragic situation and all the hoops that she had to jump through to get here to the United States. And then she finally was here and then had promptly gotten deathly ill, and here she was. And after she told that story, she said, I know my sister would not want to be like this. I know this isn't what she wants. And she was able to make that. And the resident afterwards processing that said, wow, she just needed us to witness her sister's life before she could think about talking about her death. And just being able to be, for us to take the time to bear witness to that person's life and who they have been in life, many times, and not always, I'm not giving you a panacea to make these discussions easy, but can really help inform us about why the decisions are being made that are being made. And two, really helps the family feel that you're listening to that whole person and not just about the body that is lying there that does not look like it has a history to us. And I find that valuable even when I've known patients for years and years. A lot of times what I'll try to do, and again, I'm not by any means perfect with this, is to tell what I know about that patient and then invite the family to add in what they know. That I know that she was such an independent woman, loved to do things for herself, really hated to take pills, didn't like to come into clinic, and to add the picture that I have, and then invite the family to add on about that. After you have them tell the story, then to try to seek out what the patient or the family knows and understands about their situation. Now, is that the same thing as what you spent an hour yesterday telling them? Do you think? Probably not. You spent an hour yesterday explaining things to them. That's not necessarily what they know or what they understand at this point. And I know probably many of us in here have been in a situation where you're with your own family member that is very sick or dying, and it affects your hearing and it affects your cognition. You don't hear things, you don't process things like you normally would. So having the family tell you what they understand and where they think things are first can be really helpful. Because if you're thinking that this is someone that's going to be dying within the next few days, and the family is still thinking that they're going to get completely better and walk out of the ICU, then that can help you set your starting point for where you need to start the discussion. So establishing what the family knows and letting them tell you where they think things are right now, and then expanding on that. So once they've let you know what they are feeling like, then to build on that base and expand. Okay, so these are the things that we're seeing. Here's where we're seeing the situation now, and do your medical review or summary based on extending what they know and what they've understood. And then based on that, to establish patient-centered goals. So what would be important to this person, to your family member? What's important to you? What kinds of things are most important? Do you want to be at home? Do you want to make sure that you have done everything possible to live for every day forward that you're possibly able to do, which is some people's wishes? What are the most important values that you have around what you want for the end of your life? And then the other piece is what is that person hoping for now? So that may be, I'm hoping for as many days as I can with my husband and with my kids. I know I'm going to die, but I want for as many days with my children as I can possibly get. It may be, I want to try to live to see my daughter get married, or my grandchild graduate from college, or my family member that I haven't seen for 30 years come from Cuba. What are the hopes? What are people's, and we can't, obviously we can't always fulfill those hopes, but that can really help frame the discussion if you know what people are looking for, what their values and goals are, and what they're hoping for now in this situation that's really difficult. And then the other piece that's really difficult and hard is working towards when it's family members, when the patient's not able to speak for themselves, to ask them what they think their family member would say. And I think surrogate decision making is really hard. And I don't know if any of you have, I've been in the position of having to try to make those decisions based on what someone else would want. It's really, really hard. I mean, in some ways, I think the paternalistic model of medical care, where you just said, okay, we're doing this and this, to a certain extent, for families was easier, because families can come away from these discussions with a lot of guilt and a lot of, did I do the right thing? Did I make the right decision? And sometimes family members are feeling like, how can I say it's okay for my mom to die? If I make these decisions, I'm letting her die. I'm making the decision that she died. And that's incredibly hard, a huge weight to carry with you. So it's really important to do the best that we can to frame the discussion that we're not making the decision that neither you nor I are making the decision that your mom's going to die. She has a horrible illness. She has cancer. She has heart failure. This horrible illness that she has is causing her to die. What we're trying to do right now is make the decision that she would make about what she wants. So what we're trying to do is respect her and her wishes as much as we possibly can. And that's a way that we can pay respect to the family member at the end of their life, is to do as best we know how what they would want. And it's really hard, but as much as we can with the words that we're able to say, to try to take away that idea that, oh, you're making the decision that your family member is going to die or not die, because we all know that's not the case. And then after you've had the discussion and elicited the goals, then to make recommendations based on those goals. So a lot of times the temptation is to go through the discussion and then this whole long, wonderful discussion, and then do the checky box thing. And the literature recommends that we try really hard not to do that. It's our role, after we've heard what the patient's wishes and values are, to make recommendations. And then talk about those with the family. So, okay, I am hearing that your dad really wants to go home, and he wants to do everything possible to be alive at home until he sees his brother that he's been estranged from. Okay, well, based on that, it seems like it makes sense to potentially give antibiotics, give some fluids, and some things that we can do at home to try to keep him alive until the brother comes. So you can start with, based on this discussion of what we've said, this is what makes sense. I'm hearing, it sounds like it would make sense for us to do this and this and this. What do you think about that? And then give the opportunity to give feedback. But to try to avoid getting in a situation where you're asking, do you want a blood transfusion? Do you want IV fluids? Do you want us to put a peg to him? And as separate decisions that the family has to make, but framing it based on what they've told you. And then the other piece is that things change. I know a lot of times in the media it's sort of framed as you have an end-of-life discussion, and then you do that and you're done, and you can check the checky box, and then everything's wonderful and everyone knows what everyone wants, and no more discussion or time is needed. And that's not the case, right? You can have a really long, perfect discussion one day, come in the next day, and things are totally different. And I think recognizing that that's normal is important. And I see that all the time, particularly with my home visit patients. You can have a wonderful conversation at home about what people might do in theory. And then when that theory becomes reality, sometimes that all goes out the window. And you're going back through and having the same discussion. And that can be either way. Sometimes people that really feel like they wouldn't want aggressive intervention when you have this discussion in theory, then when something happens the next week are, oh my gosh, we have to do everything. And then instead of a linear model, it really feels to me like it's sort of like a ping pong model of this process around the end of life, where you're kind of, people bounce around before finally making the decision that is going to be the final one. That really is not final until the day that that person dies, because changes can be made at any point and at any time. Also, people that thought that they really wanted full code, wanted everything, again, can see what that really means in the ICU or in the hospital and think, oh no, actually this is absolutely not what I mean. I didn't know it was going to be quite like this. So things change. And not being frustrated by that, and that doesn't mean that you haven't done a good job with having the discussion or with hearing them out. It just is, this is really hard. And people's emotions change over time, people's thoughts change over time. It's just a really hard discussion. So I will close with that and do my best to answer any questions. Like I said, anything I can't answer, I'll get back to you about later. Elena.
Something that often comes up every time I come to my clinic is people requesting letters to include relatives,
And sometimes it is. They will sometimes, it depends on the country and what they're, but and where they're coming from and that country's relationship with the United States and all of those things. So I don't think there's one answer to that. But I think that it's not unreasonable if someone is dying to write a letter saying, this is this person's medical status. They are requesting that the presence of their family member at the end of life. And then based on writing that letter, then it's the job of immigration and all of those kinds of things to make the final decision. But it's a very reasonable letter to write. If someone's not seen their mother and they're dying, I think that's a very reasonable letter to write. You put the medical situation to the best of your knowledge, and that they are requesting the presence of this family member. That would be helpful for them. And then after that, the legal decision is not ours.
So, Kara, I'm wondering if you can speak to the conundrum that we have where in the outpatient setting, where I think many of us are very used to the inpatient setting, dealing with an acute event, admission, and maybe sort of the writing on the wall. But in the outpatient setting, where we're so time pressured,
Yes.
and often the people who come in to see us and need to have this conversation are the people who need 7 things to be addressed in that 15-minute visit. What's your sort of pearls for managing that kind of situation?
If I had the answer to that, it would change my life totally. So I'm not going to pretend that I do. But I mean, all the things that we all know, but that are really hard to do, like trying to have the patient come in specifically to have that discussion, blocking out time if you can, or even if there are any of those things that can wait, to say, okay, we're here today, and this seems like it's something really important to talk about. Can we make another appointment to talk about your diabetes and your blood pressure? And okay, your hemoglobin A1C is whatever, and we're going to leave that for today and put this at the front. But it's hard. I wish I had.
For the advanced directives list of resources you offered, is there something where you might, like at the end of the visit, be like, okay, we dealt with 7 things today. Here's what we need to talk about next time. I'm going to give you this thought-provoking something if you are okay with reading in English or Spanish. What do you give to sort of trigger that as a next visit?
So mine, the 5 wishes is usually what I use for mine. Or I will, a lot of times, the other thing that I do is that I usually do the healthcare proxy discussion as separate from the kind of end-of-life goals discussion. So that's usually sort of my warming up kind of thing. If you're incapacitated in the hospital, can't make decisions, who do you want to make decisions for you? I usually do that as a separate decision. So a lot of times I'll be, one time, and then I'll send them home with a healthcare proxy form. Think about this. You can talk to your family. Come back and we can sign this next time that you're in the office for the healthcare proxy form. And then the end-of-life discussion is kind of the building discussion after that. I think Karen and then Ed.
A lot of times when we have these long, complex things, we ask nursing to sort of step in and run through form questions like DSME, or I use it a lot for MOCA, completing a MOCA or a mental status. Is there something we could give nursing, or even make the 5 wishes available at nursing and have an appointment to do like an initial conversation so they get the juices flowing and they have thoughts down in the note, and then have them come see us? We only have like 30 minutes, and they might have like an hour or 45 minutes. And then if we have like a pre-thing they could do, then the patient would come in sort of prepped to have the conversation.
And again, I think that over time, with education, there's lots of things that would be possible. In my experience, I think that works well with if you want to do a healthcare proxy, that nursing or even the medical assistant can talk to patients effectively about who they want to be their decision maker, and then you can follow that up and add on to that discussion and give the
and it's an order. But
yeah, and then
somebody did some of the education and prep, then we get to it more effectively.
But I think the barrier to that is that this is a really hard discussion. And we've had, I think all of us find this to be a difficult discussion, and we've had at least a little bit of training in this. The nurses, we would be starting essentially from zero, and a lot of them are uncomfortable and have their own, and this is a thing, like I think for all of us, we've had to work through our own emotions around death to be able to have that discussion. So I think that it might be a hard I don't think it's impossible, but I think it might be a hard project to do. But definitely with the healthcare proxy forms, and the other thing I'll do all the time is I'll have because you don't have to sign the healthcare proxy form. That can be, so I will have the conversation in the room, come out and tell my medical assistant, he would like for his son Sam Fernandez to be his healthcare proxy, can you get the form and help him
That's what I do.
fill it out? And
The only other thing is to Andy's question is that obviously, you remember is that if you're going to have somebody come back, have them come back to the last appointment of the day or the last appointment, and then if they run over, the rest questions.
Can you comment at all or have any suggestions? I often find I'm having this discussion with a patient who's got some degree of dementia, and I've sort of gotten some signatures on forms where I sort of feel like not great about it, and I certainly have had a couple of patients who've gone to get formal guardianship, and it's been quite a process.
It is
and
quite a process.
Is there something in between that, or?
So I think for the most part, the feeling of the literature is if that patient is able to, and over the course of dementia, that you are able to express particularly who you would want to make your decisions is something that would go relatively late. You don't have to be able to know the year and who's president to know who you want to help take care of you or make your decisions. So the idea has been that if the patient is able to verbalize that, and they're able to verbalize, who they want to be their caretaker, then that is adequate to be able to sign the healthcare proxy forms. In terms of some of the advanced directives, I think that's harder. That's a higher bar because they're cognitively more difficult decisions. But usually in that setting, if you can get the healthcare proxy, then you can work through the other things with the person that's a healthcare proxy. However, if you have someone that really cannot speak for themselves and really can't sign, it's difficult. But that's where you end up having to go through the guardianship process. And in Massachusetts, that's quite a barrier, and it's a significant process to go through. And I think we've all seen that, because to go into a nursing home, there has to be a legal healthcare proxy in place, and I see that in home visit patients, before they go into a nursing home too. If I've taken them over when they already have end-stage Alzheimer's, there's no healthcare proxy in place, then you've got to go to court to be able to establish that.
But if someone, I guess I'm wondering what standard you use related to Steve's question, if someone recognizes their family member with whom they live, who is their caretaker, and enjoys a loving relationship with that person, even if they don't, even if they're otherwise really cognitively impaired, do you feel like that's an okay standard to identify for them to say, yes, I want this family member to be healthcare proxy, or do you hold to a higher standard of understanding?
And I think that's hard, and I kind of on a case-to-case basis. The thing that's hard and the thing to remember is I have seen a couple situations where a family member will come in from left field and say, my dad signed this when he was already demented, and contest the validity of it. So if it kind of depends on if it's a patient that I've known for a long time and I've had discussions with them over time and they've always kind of identified that person. Ideally, I would have already done the healthcare proxy anyway in that situation. Or if it's very clear who all the players are, then I'm more comfortable, and all the players are on the same page, then I'm more comfortable with that than if there are, family members, particularly siblings, that are floating around that aren't accounted for. I think it's hard. I think it's a judgment call, and we all do the best we can. If I'm comfortable that I feel like I can establish for myself that is what that patient wants, then I will do it. Legally, it's harder. So, thanks everybody.
Thank you.